This is animal physical therapist and author Susan Davis, and thank you for joining me today for a presentation on phantom scratching in dogs. This is part of a research project for evidence-based practice that I did as a student in the Transition Doctor of Physical Therapy program at Rosalind Franklin University of Medicine and Science. The case that prompted my project was a patient I encountered, Timmy W., a Chihuahua Dachshund mixed breed dog who I became aware of in 2012. Timmy is a neutered male with congenital anomaly of the atlas and axis. In particular, he has a malformation of C1 atlas and C2 axis with aplastic dens of the odontoid process, causing moderate to severe subluxation. MRI reveals mild compression of the spinal cord at C1 and C2. Timmy had stabilization surgery performed on May 4, 2012 to relieve pressure on the spinal cord and stabilize the C1-C2 joint using a ventral craniocervical approach. His subluxation was reduced and fixated with transarticular screws, pins, and bone cement. Physical therapy was initiated at 12 weeks post-op. Timmy's problems needing to be addressed included a severely roached posture, which in the dog is similar to a kyphosis or a rounded spine in the human. Also balance, strength, and gait deficits. PT treatment included functional electrical stimulation, therapeutic exercises, balance, and gait activities. Timmy had PT for 3 months and regained anti-gravity strength and reciprocal hind limb movement, yet his gait remained ataxic. His top line posture was improved with only mild roaching, and he had fair plus balance in static standing, fair balance in dynamic movement. So at that time, physical therapy was discharged to a home program. This is Timmy having one of his PT sessions, and I had him on top of a 40-centimeter peanut-shaped physio ball by the company in Italy called Gymnic. And here he's doing some proprioception and core as well as balance training. In 2016, 4 years after Timmy's surgery, he began to experience phantom scratching, increased tetraparesis, which is similar to quadriparesis, and worsened gait ataxia with knuckling deficits. Testing was done with MRI, CT scan, radiographs, and spinal tap. Ruled out were migration of pins or other hardware failure, focal seizures, herniated discs or tumors, and there were no cerebrospinal fluid abnormalities. Positive findings included artifact associated with the implant, which was identified as scar tissue at C2, also a focal area of hyperintensity on T2, identified as a glial cyst at the second cervical vertebrae within the spinal cord parenchyma. There was also subtle dorsal ventral flattening of the spinal canal at C3-4 and evidence of mild brain atrophy. What does phantom scratching look like? So hopefully on this slide you can see a smaller space on the screen that says watch on YouTube, and click on that, which I'm going to do right now, and it will take you to the video. Pharmacological intervention for Timmy included the following: amantadine, gabapentin, phenobarbital, Keppra, and omeprazole. His symptoms abated after 1 week on the medications, but started up again 6 months later. It was managed over the course of the next year with medications which were adjusted during exacerbations. By the fall of 2017, Timmy's episodes of phantom scratching became more frequent, and both he and his owners suffered a consistent lack of sleep due to the constant and excessive scratching. Physical therapy started in October of 2017 to try and reduce the phantom scratching. This slide outlines the physical therapy intervention we did at that time. Evaluation revealed a new finding. Timmy had now a gait deficit called high goose steppage of the forelimbs and stomping of the rear limbs, left worse than the right. The high goose steppage of the forelimbs is usually an attempt to unload the cervical spine, and the stomping of the rear limbs is similar to what a human does with lack of proprioception. A rapid literature search was performed because I had never treated this situation before. I found cold laser was found to exacerbate phantom scratching in 2 articles. The Assisi Loop, which is a targeted pulsed electromagnetic field device, was found to be very helpful in 3 short videos that I saw. So I had to formulate a treatment plan using the best evidence I had at the time, plus clinical judgment. I decided on a superficial massage, myofascial suboccipital release, manual cervical distraction, the Assisi Loop, stretching the hind limbs and doing tone inhibition techniques, and proprioception exercises. Now, Timmy's owners, Mr. and Mrs. W., reported a significant decrease in phantom scratching right after the physical therapy first visit, and Timmy was able to sleep uninterrupted for 5 to 7 hours. After 3 visits, things were so reduced with the scratching that we ordered the Assisi Loop for the owners to use at home twice a day. Along with the medication, this added physical therapy produced good results with brief exacerbations of the scratching, which usually lasted anywhere from 20 minutes to up to 3 hours. And this improvement covered an 11-month interval. This is what the Assisi Loop looks like. It's a circular device. Has different sizes. For Timmy, we put it right around his neck, almost like a necklace, and there's a little activation button that's pressed, and it provides 15-minute treatments. It shuts off automatically. It's a great modality for an independent home program. So phantom scratching was pretty well controlled over that year, but then it exacerbated again early in September 2018. In addition to the scratching, Timmy also showed signs of cervical pain with facial grimacing, head tilting to the left, and torticollis with the rotational component. And he would self-position his neck in elongation when upright, almost like he was trying to give himself some traction. When he was lying in prone, he would self-position with his front limbs horizontally abducted so that he could get his ventral part of the spine and neck closer to the ground and give himself traction. Retesting was done, and everything was unchanged except this time the cerebrospinal fluid showed rare reactive lymphocyte secondary to antigenic stimulation. This is a photo of Timmy with the painful grimace on his face, and you will note that he's holding his neck rigidly and slightly in a head tilt to the left. This is a picture showing more of an actual torticollis where he is doing some cervical extension. He is positioning himself in side bending to the left, rotation to the right. This slide shows himself positioning in straight cervical extension to elongate the neck. This shows Timmy in the prone position with his forelimbs widely horizontally abducted. Medication changes were done at that time. An additional dose of phenobarbital, a quarter tab of 15 milligrams, was added once a day. Timmy was also started on tramadol and additional prednisone added to his program. Symptoms dramatically stopped. Mrs. W was instructed to begin to wean the prednisone, but as soon as she began to wean it, the phantom scratching symptoms returned, as well as the pain in his neck. So Timmy went back on a full dose of pred, followed by tapering to a maintenance dose of 2.5 milligrams once a day. Tramadol was discontinued. By the late fall, Timmy had improved and was very comfortable with his daily activities and much less phantom scratching due to these medication changes. And they also continued using the Assisi Loop. So for my research project, I wanted to explore how physical therapy might be helpful with other dogs that have this condition. And I formed what's called a PICO Question. In research, a PICO Question is structured so that you have an organized way of going about your research. PICO stands for Population, Intervention, Comparison, and Outcome. My PICO question was, are desensitization techniques with drug therapy more effective than drugs alone in decreasing phantom scratching for dogs with congenital cervical spine anomalies? The search strategy for literature was a combination of keywords, which are listed in the slide, such things as phantom scratching, neuropathic itch, syringomyelia, Chiari defect, failed back surgery, etc. Further refined by combining keywords into mesh headings as listed with animals / gabapentin / neuropathic itch, or physical therapy / desensitization / syringomyelia, etc. The databases I searched were Medline, the Cochrane Library of Systematic Reviews, the Rosalind Franklin University of Medicine and Science Boxer Library, the Physical Therapy Database PEDRO, and veterinary specialty databases, the Merck Veterinary Manual, Vet Systematic Reviews, and International Veterinary Information Services. The generalized databases initially yielded, as you can see, 578,000 plus references. By adding filters and mesh terms, the search was brought down to 14,600 and change, then to 4,490. And as I further refined the terms, got it down to 162 articles, and then eventually a set of 29 articles, which was saved to collections in Medline. Now then I went to the specialized databases in physical therapy as well as veterinary medicine, and that yielded an additional 8 articles. So at this point, between the general and specialized databases, I had 37 articles. Levels of evidence for each were identified using Sackett's levels and Oxford scales. Quality of each article was initially triaged using a screening rubric that I developed as an assignment in this class. Once they were triaged, a more detailed analysis was performed using the consort statement the Pedro scale, and McDermott's scales. So from those 37 articles, I was able to scrutinize the quality and further reduce my list to 15 articles on which to base the research project. The 15 articles comprised 2 that were level 1A, 1 level 1B, 1 level 2B, 6 level 4s, and 5 level 5 studies. They were each carefully reviewed. Evidence comparing desensitization techniques and drug therapy, such as we use for Timmy, for improving the outcome for phantom scratching, does not currently exist in the literature. However, partial supportive evidence exists identifying specific spinal cord locations and neural pathways associated with phantom scratching. Animal physical therapists encountering persistent phantom scratching may consider this as background information, though it is not statistically significant as evidence. These were the results of my study. So to go through the background information and see a way that we can apply it in physical therapy, we'll start with a description of phantom scratching, and you've seen the video. It is called clinical pruritus, which is the medical term for scratching. It is air scratching of the limb. There's no contact with the skin. It's paroxysmal, involuntary, and reflexive. It's triggered by some type of neural facilitation, even auditory stimulation. Its hallmark is a lack of purposeful skin contact. It was described over 100 years ago by Sherrington, who did studies in spinalized animals. Affected patients with phantom scratching do not typically behave as though they have signs of pain, and the patterns of phantom scratching can be episodic in nature. When comparing the itch to neuropathic pain, the following information applies. Phantom scratching is a type of neuropathic itch caused by non-histamine type neurological phenomenon. It is a particular form of neuropathic itch without skin contact. In comparing it to neuropathic pain, phantom scratching is not always viewed by veterinarians and scientists as a painful condition, so this term, neuropathic pain, is less applicable. However, phantom scratching is sometimes thought of as a manifestation of neuropathic pain and appears to be received along the same or similar sensory pathways. Therefore, the dog's phantom scratching is thought to be a reflexive attempt to block, modulate, inhibit, and decrease pain or irritating itch signals received at the superficial dorsal horns, outer lamina 1 and lamina 2, then sent to the brain via the ascending spinothalamic pathways. Dogs that typically have this condition are toy and small breed dogs, particularly Cavalier King Charles Spaniels, 5 years and younger. Other breeds having phantom scratching include Chihuahua, Yorkshire Terrier, Miniature and Toy Poodle, Shih Tzu, Pomeranian, and Japanese Chen. Phantom scratching is seen more often in male dogs and is more likely to occur in mid-cervical lesions. That brings us to location, or causative lesion or congenital anomaly in the cervical spine. Starting at the top, you have COMS, which is caudal occipital malformation syndrome. You also have occipital C1 with Chiari malformation, which is a foramen magnum obstruction, where the cerebellum and the brainstem actually extend down through the foramen magnum. Next level down would be your C1 and C2 with atlantoaxial instability. This is what Timmy had. With rostral displacement and angulation formation of the axis at the odontoid process, or with the dens completely absent, as with Timmy. Moving further down from the upper cervical spine to the mid-cervical spine segments, the cause there is syringomyelia with the presence of a syrinx, usually between the C2, 3, and C5, 6 spinal segments. Surgical treatment for Chiari defect, syringomyelia, cranial occipital malformation syndromes, a foramen magnum decompression is performed. For atlantoaxial malformation with instability, realignment and fixation surgery is performed with cortical bone screw, K-wire, and polymethyl metacalcitrate 10 cement. Most surgeries are successful. However, complications from surgery include scar tissue adhesions, cervical spinal cord compression, neuropathic pain, phantom scratching, and ataxia. Patients having post-op symptoms of phantom scratching and pain are considered to have poor outcomes and are referred to as failed surgery cases. The dorsal stabilization failure rates are documented up to 44%. Ventral stabilization technique, such as Timmy had, have a lower rate of failure at 18 to 38%. Phantom scratching can occur post-op anywhere from 12 to 17 months up to 2.3 years for documented cases. Pharmacological treatment in these cases is done to inhibit the itch signal by mediating dorsal horn inhibitory interneurons influenced by sympathetic noradrenergic neurotransmitters and postsynaptic receptors. This is usually accomplished by drugs which inhibit and reduce excitation presynaptically via the GABA agonists. GABA, which is gamma-aminobutyric acid, is an inhibitory neurotransmitter. Gabapentin, also known as Neurontin, exerts inhibition by binding to GABA B receptors in presynaptic terminals. Gabapentin is widely referred to in the literature to treat neuropathic itch and phantom scratching. Benzodiazepines that bind to GABA A receptors for sedation are not shown to be effective. Antihistamines, nonsteroidal anti-inflammatory drugs, and steroids have each been found ineffective or only minimally effective. I will note that the prednisone steroid was effective for Timmy. Pregabalin, or also known as Lyrica, has partial evidence in helping neuropathic pain and itch by decreased release of the excitatory neurotransmitter glutamate. Keppra, an anti-seizure drug, is partially effective in controlling phantom scratching. Oxcarbazepine, an anticonvulsant, is used in human pain for peripheral nerve involvement and has little evidence in the veterinary field to support effectiveness. Oral analgesics might be effective for post-op scar tissue. Again, no evidence found on use of steroids for phantom scratching in the literature. Medications such as acetazolamide are used to decrease cerebrospinal fluid production for patients with cranial occipital malformation syndrome and atlantoaxial instability in an attempt to control unwanted pain and other unpleasant sensations. Surgery is not always successful, and as we've seen, can have post-op complications. Medications are not an ideal long-term solution and need continual management and adjustment. They can also be expensive. The patient may develop adverse reactions. Therefore, physical therapy and other adjunctive treatments may be of benefit for phantom scratching. MRI studies of dogs afflicted with phantom scratching consistently show that the superficial dorsal horn is the primary location for pain and itch perception, with receptors in the outer laminae 1 and lamina 2, which, as you know, connect to the ascending spinal thalamic tracts, which terminate in the thalamus of the brain. Moving deeper into the superficial dorsal horn, lamina 3 and 4 contain receptors and synapses for the perception of light touch, proprioception, pressure, and vibration. These connect to the crossover ascending pathway, which terminates in the cerebellum, which is the spinocerebellar tract. This is a slide to review the superficial dorsal horn, and I have circled the lamina in the upper right-hand side. And you will note that laminas 1 and 2 routinely receive pain and itch signals, whereas 3 and 4 receive and process signals for vibration, proprioception, and light touch. Studies of rodents and non-human primates show that the sensation of itch is processed in both the outer and deeper lamina of the superficial dorsal horn, and that touch and pressure receptors may share overlapping parallel travel pathways, the same as noxious pain signals, through a subpopulation of neurons and interneurons that respond to itch-producing agents. Therefore, we can use other tracks to help block itch sensation working through a central mechanism. This indicates that physical therapists need not choose only modalities and techniques that act directly on the same primary afferent fibers of the spinal thalamic tract responsible for signaling itch. Instead, we have the possibility of using mechanical, vibratory, and light touch and superficial massage therapies to modulate neurological itch and phantom scratching in dogs via the deeper lamina of the superficial dorsal horn. The gait theory supports the use of pain-modulating, though comfortable, noxious modalities such as cold, heat, and TENS to provide a mechanism to block pain signals received at the superficial dorsal horn from reaching the brain. However, recent studies have refined the theory as a leaky gait, blocking intense pain signals but allowing weaker pain and itch signals to pass through. Therefore, the use of heat, cold, TENS, and traditional forms of electrical stimulation might not be effective in reducing phantom scratching using receptors and synapses at lamina 1 and 2 of the superficial dorsal horn. Continuing with background information found in the literature were 2 studies on spinal manipulation in lab rats. One study shown alleviated neuropathic pain in lab rats having undergone surgical placement of stainless steel rods near interforamen lumbar 4 and 5 for dorsal compression. Manipulation treatment was provided using an activator. Postmortem studies of spinal cord tissue of the spinal manipulation group showed that endogenous anti-inflammatory cytokine interleukin 10 was increased and contributed to neuropathic pain relief. Another study compared rats receiving injection of endogenous metabolites as inflammatory mediators. They were treated with spinal manual therapy techniques and compared to a sham group receiving nonspecific treatment. Those undergoing specific manual therapy treatments to the spine had significantly increased mechanical nociception thresholds. Low-level laser therapy at 808 nanometer wavelength is shown to be effective in improving pain tolerance in rats undergoing surgical spine compression, at the lumbar intervertebral foramen. One case study found on a PT blog described cold laser, however, as exacerbating phantom scratching in a spaniel that had syringomyelia. My own clinical experience combined with this background information in the literature showed that physical therapy intervention, when it was added to the patient's drug regimen, was immediately effective in sharply reducing the frequency and duration of phantom scratching. The Assisi Loop, manual traction, suboccipital myofascial release, light massage, and proprioception techniques were helpful. Physical therapy did not result in a decrease or elimination of drugs, but it reduced the phantom scratching when added to the pharmacological regime. The clinical decision I reached after combining my clinical experience with background information found in the literature is as follows. For desensitization of phantom scratching from abnormalities at all cervical levels, surgical and non-surgical, superficial massage, myofascial release techniques, light therapeutic touch over trigger points or acupressure points, soft bristle brushing, vibration treatment with manual device or vibration board, and whole body proprioceptive closed chain activity. Rationale is based on the use of receptors and synapses in the deeper lamina 3 and 4 of the superficial dorsal horn, which respond to light touch, vibration, and proprioception. Just as a reminder, these lamina connect, cross over in the spinal cord, and ascend through the spinocerebellar tracts. Use of electrical stimulation using low-frequency, subthreshold, microcurrent stimulation and targeted electromagnetic field Assisi Loop stim may be effective for desensitization of phantom scratching. Rationale is that I had good results with my patient using the Assisi Loop. Both of these types of stimulation are also subthreshold, non-noxious stimuli, which should provide a nuance to modulate pruritus sensations which might otherwise escape the gate control theory. Above threshold, noxious stimuli such as cold and heat, TENS, neuromuscular electrical stimulation, and Russian stim should not be used for phantom scratching. The rationale is they would not be effective to reduce neuropathic itch based on the leaky gate findings present at lamina 1 and 2 of the superficial dorsal horn. Additional clinical decisions are for patients with specific post-surgical fixated atlantoaxial lesions with scar tissue. Manual cervical traction or distraction may be of help. Also, manual spinal mobilizations using Maitland grades 1 through 4 at the mid to lower cervical segments and mild dural stretching techniques to release pressure and reduce restriction caused by post-op adhesions should be effective. This rationale is based on clinical experience and 2 bench research studies confirming the benefit of manipulation via activator and manual spinal therapy involving spinal cord compression symptoms post-surgery. Precautions and contraindications. Contraindicated treatment for phantom scratching, based on my research and experience, would be motor-producing, above-threshold, depolarizing electrical stimulation, such as neuromuscular E-stim, TENS, and Russian stim. Maitland grade 5 manipulations should be contraindicated at the cervical spinal joints. Continuous ultrasound is an absolute contraindication as internal fixation is present. Questions remain on the use of low-level laser therapy, pulsed non-thermal ultrasound, acupuncture, and extracorporeal shockwave therapy. Integrating research, critical thinking, and my clinical experience. Did this study directly answer my PICO question? It did not. There is no evidence in the literature to answer if adding desensitization physical therapy techniques to drugs is better than drugs alone in reducing phantom scratching in dogs with congenital cervical spine anomalies. What did I learn that was new? I was able to correlate information about neurological pathways and interconnections within the spinal cord's superficial dorsal horn in relation to the mechanism of neuropathic symptoms such as phantom scratching. What did I observe that was new with my patient Timmy when the phantom scratching and neck pain began? His high goose stepping and stomping gait correlated with the onset of his phantom scratching. His self-positioning into cervical extension with head tilt and the neck began with the onset of cervical pain. Physical therapists should be alert to observation of these specific gait deviations and postures during the patient examination, as they may indicate the need for intervention and veterinarian consult or referral. Conclusions. It is known that long-term use of medication does not always provide a sustained solution for recurring phantom scratching. A need exists for alternative or adjunctive non-pharmaceutical interventions to help reinforce and provide lasting results. Based on clinical experience, I recommend that physical therapists can apply defensible intervention concepts to the background information found in the current literature for the purposes of pruritus desensitization and phantom scratching decrease, such as using light touch, proprioception, and vibration. The Assisi Loop, superficial massage, manual traction, and spinal joint mobilization may be of benefit in selected cases. These interventions can be administered concurrently with medication with minimal, if any, risk of exacerbating phantom scratching. Treatment results for modulation of phantom scratching in affected patients must be documented to support a basis for future research. This concludes the program. Thank you for listening.